On the very first episode of the Physio Foundations podcast, I'm talking to Associate Professor Peter Malliaras from Monash University about the fundamental knowledge and skills that you need as a clinician, physiotherapist, or physiotherapy student to help people with tendinopathy. Welcome to the Physio Foundations podcast. It's a podcast about the foundational, fundamental knowledge and skills that underpin expert clinical practice. I'm your host, Luke Perraton, and on the very first episode of the Physio Foundations podcast, I'm delighted to announce my guest is Associate Professor Peter Malliaras from Monash University. So Pete is a colleague and friend of mine at the university. We work together on various research projects. I'm supervising research students and in teaching. Well, he's the perfect guest to have on first for the podcast. So, Pete, thank you and welcome.
Thank you very much, Luke. Thanks for having me.
Great. So let's just go into your current position first. Just tell the listeners a little bit about yourself, what you currently do, and your origin or your foundation story, what makes you're an expert in tendinopathy as a clinician and a researcher. But you didn't get there overnight. What's your foundations?
Yeah, so basically I pretty much went into research quite early in my career and was fortunate enough to work with some good people. Tendinopathy space is quite small, so once you start researching that area, you meet a lot of people very quickly, and working with all these people that you read their papers and you sort of admire their work was a really good experience, and that was during my PhD. And then that sort of mushroomed on to going overseas to the UK. And I think in terms of, doing a PhD is one thing, but making it into a passion post-PhD is a different thing. And that's probably the thing I want to highlight. You then have to do almost harder work post-PhD to focus on that area, to learn as much as you can via the literature, but also work with the best people in that field. And so I went overseas and did a postdoc with people who were doing a lot of tendon research, and like Professor Nicola Mafuli and Dylan Morrissey, and that turned out to be probably the turning point in terms of learning for me. And that concentrated time, 5 years in the UK, I worked in tendon clinics where we would just see tendon patients with a whole group of experts from different fields. And that experience was probably the thing that I learned the most from, and that I sort of then was able to go into the sort of career that I have now.
We're going to, in this episode, we'll go into the knowledge and skills that you really need as your foundation if you're going to be helping people with tendinopathy. But it is important for the listeners to know who they're listening to and where you've come from. So let's get into the specifics here. So what are some of the most, all that learning you've done over many years, what are some of the most important things that physios and physio students or other musculoskeletal clinicians should know about or think about as they go into the clinic and they're going to help someone manage a tendinopathy?
It's a really good question. It's one that sort of makes you stop and think, because it's in one way you can sort of think about it as a lot of musculoskeletal conditions that we treat treated with similar principles. So you treat them with trying to educate people and empower them about the condition, how to manage it, and trying to lay their fears, and then try and set them on the right path with activity and with exercise. So tendinopathy, I guess the principles are very, very similar, but so I guess getting the basics right is the first probably lesson for a new grad. I'm just trying to think back when I was a new grad. I remember distinctly working in a practice in Northcote in Melbourne, and I distinctly remember sitting in a room and doing ultrasound therapeutic ultrasound, as well as frictions for tennis elbow. And I've got this visual memory of it that just, haunts me, I guess you could say now.
I told the Monash Physio students recently the same story.
Yeah.
And there was some ice involved as well, I think, and advised to do nothing and rest. I think there was all sorts of wrong things happening 25 years ago.
That's right. And it takes me back to like the way my thought processes were at that point. It was basically very uncritical. And I would think, okay, so I've been taught in second year or whenever it was, you got to do this protocol, the Stadish and Kerwin protocol it was then. You got to start with this stretching, you got to go into this, then you got to go into this eccentric exercise, then you got to finish off with ice and frictions or whatever it was. It's probably not right, but and I just uncritically just followed that like a robot. And that takes me back to sort of my thought processes. So I guess for a new graduate, think about the basic principles that you're trying to achieve with a patient who's got a tendon problem. And really what you're trying to achieve is you're trying to make them feel more comfortable in terms of their pain. And that will come from talking to them largely to allay their fears. That's probably the most important thing. Allaying their fears, setting their expectations, allowing them to understand what they should and shouldn't do. If you're doing that, you're doing a fairly good job already, much better than what I was doing at that Northcote clinic there 25 years ago. But then if you can go beyond that and start thinking about exercise and doing some exercise that's going to load the tendon as well, starting off from a point of view of trying to set something that's going to be suitable for them based on how much symptoms they have in their function. I think those basic principles, if you're applying them in a critical way with a sort of idea of who is in front of you rather than a cookie cutter sort of way, I think that is really a good starting point for new grads.
So be critical of what you're doing and what you're thinking and your thought processes, and always bring yourself back to those basic principles. And it's interesting that you started with education and allaying fear, and then you started talking about exercise, and then you've already steered us away from the dinosaur days of icing and doing transverse frictions and ultrasound and things. But all the listeners know that that's what used to happen, and that the tendinopathy research field has moved along so much. But it is interesting to reflect on where we've come from.
Yeah,
and
definitely. They were in a way, those days were simple because you just had your recipe, you go into your clinic, you apply your recipe, you do your stuff, and you go out and you don't have to think too much. But also there was a whole stack of confusion because you're always thinking, am I doing the right thing? Why am I doing this thing that I'm doing? So thinking critically, I think, and deeply about everything you're doing is really important.
Well, let's take a step back and talk about why people get tendinopathy, because that's going to be fundamental to the treatment and the assessment and the treatment you do. So what are some of the causes and contributing factors? I know that's quite heterogeneous and there's lots of different causes and contributing factors, but generally.
The probably the biggest one is just activities and change in activity. So people that if we talk about lower limb, starting to use your arm more, say at work or overhead activity, repetitive activities like sport, like tennis or other things, can bring on a tendon problem. With the lower limb, it tends to be repetitive stretch, short and cycle activities. So it could be things like walking, or could be things like running, any sport activities. So I think the starting point from a point of view of understanding a tendon patient is trying to understand how much loading they're doing in those sort of domains. So you've got to understand how much what type of load and how much they're putting into their tendon, and then you've got to that's your starting point for then thinking about, do I need to be thinking about reducing their load or increasing their load as part of treatment. But then there's other risk factors like the person's general health. So they might be that they are a smoker and they've got diabetes. So that could increase their risk of and also make it a poorer prognosis for getting better. It could be that they're a female in menopausal type period, which is going to be also possibly a risk factor. The other major ones, so metabolic disease, hormonal changes in females, they're really the major ones. There's not a lot of evidence that, say, if you've got really poor biomechanics or you've got really poor strength, that's going to be a risk factor. There is some, but there's not a lot of evidence for those, and it's quite variable. And I think that's why the evidence is not clear, because for some people, strength might be a risk factor. For other people, it may not be at all. So it's quite variable, and we don't really have a lot of certainty on those. But again, go for the major ones, go for load and really explore that, and then look at any major general health issues as well.
So what I'm getting from that is the lesson here is to, obviously, we're not here to tell clinicians and physio students how to do an initial interview and to structure that, but just perhaps to think from the perspective of an expert, how we can look more broadly at the problem and the bigger picture as well, and think about the person. So, if we get to the end of our initial interview here and we've considered contributing factors and causes, and perhaps not as strong a links between some of the, so say strength, for example, and as a contributing factor, what about when we get into a physical examination and look at impairments? So what are the main impairments you see when you measure things?
So the main one is that people present with pain. So pain is the biggest one. So we need to be measuring that in a way that we can then sort of look at how it's changing over time. So get into the habit of assessing pain scales. So it could be how much pain, what's the worst pain you've had over the last 7 days? Or how much pain do you have with a hop test or with a squeeze, a maximal grip test, or, those types of things. So pain is a really important one, but the other impairments are things like generally a lot of people will have motor impairments. So they'll have reduced strength on their affected side. Again, you want to get into the habit of trying to measure those. And it could be that you just do tests, like repeated tests that, will give you some idea of their endurance, or it could be that you've got a dynamometer, handheld dynamometer in your clinic. You can measure them that way. We're getting more and more, I guess, high tech with how we measure things. And that's very, very important. So as a new grad, you want to be thinking, and again, critically think through things. How do you know that someone has got a strength impairment? Is the test that you've done reliable enough and valid enough to be able to tell you that? And if you've just done a sort of, what do you call it, a maximal sort of hand pressure resisted with your hand.
Manual muscle test.
Muscle test, thank you. It may not be reliable or valid enough to actually tell you if there's a difference or if this person is weak. So that's important. You don't want to fall into the trap of something like a confirmation bias type trap where you're thinking this person's got a tendon problem, they're likely to be weak. I'll do a manual muscle test. Oh, look, they are weak. You don't want to fall into that trap, because that's a classic confirmation bias trap where you're not using the right tools. Not everyone with tendinopathy will be weak. Not all of them will need a strength program, in inverted commas. So it's I think it is important to think about, how are you arriving at your answers, and the same thing with diagnosis. What gives you certainty that diagnosis is the right one? What gives you certainty that those impairments are reliable? So those things are important to think through.
So talking really generally about upper limb and lower limb tendinopathy, but just generally, so we've talked about pain, thinking about pain during a functional task, for example, a heel raise or a grip strength test, pain in the last 7 days, and then also measuring strength. Consider ways of objectively measuring strength and then thinking about how much error is likely to be in that measurement of strength. Anything else that you would be in the fundamental management of tendinopathy in terms of measurement, things that you have to track at the impairment level? Talk about the functional and participation level later. Pain and strength are big ones.
Yeah, pain and strength.
We could talk about function if you like as well, or anything else that you'd measure.
With measurement, basically as much as you can. I think that's what is going to separate us apart in the future. People that measure and people that don't measure, because it's becoming much easier to measure things in the clinic. So in the clinic now, with an Achilles patient, which is the cohort that I specialize in, I'm able to measure maximal voluntary contractions, rate of force development, even hopping type metrics, like looking at how they hop from a point of view of how efficient they are with hopping. And you're able to do these relatively cheaply. So all these things are possible. Now, that might not be something that every clinic wants to or can set up, but you can certainly look at the literature and find robust, reliable, and as valid as you can within your budget and within your clinic scope measures that you can use for strength and for functional things like hopping. So, for example, hopping, you can use apps that are pretty cheap that allow you to measure things like even vertical stiffness and hopping height and things like that. So these functional things, again, get into the habit of measuring as much as you possibly can. It's good for your own learning. You might be surprised sometimes to find that the deficits that you expect are not there, but it's also good for the patient as a motivator if the deficits are there, and you're then setting them a program they have to stick to, and you're sort of you've got the evidence that you're not guessing. You're not saying, I think you're weak, therefore I'm going to give you this. You're saying, I know you're weak because we've got this data that's telling us you're weak. I'm going to set you this, and then we're going to look at this number going from here to here in the next few weeks.
Goal setting and motivation.
Exactly. And that makes a huge difference for patients and also for your own enjoyment. I find it so satisfying to be able to say to patients, this is what I've clocked you at, and this is what I want you to be at, and this is how we're going to achieve it. So it's really satisfying if you can do that.
And look, a key point you made earlier was not everyone with tendinopathy will be weak, and they may not need a strengthening program. So looking beyond the things that you think will be a problem and actually measuring and getting lots of data points for hundreds, even thousands of patients over your career and building your own bank of clinical evidence.
Exactly. And that is really what it's about, because if you can have then the discussion about what do trials tell us? Trials tell us about the average person. So this is how the average person is going to respond to an exercise intervention, but it doesn't tell you about your patient in front of you. And it may be that your patient in front of you, because of your experience, you can start to think they maybe need something different. Not so much this. We know that yes, exercise works for the average person, but this guy is really strong, has tried it all before, has failed. Maybe I'm going to give them something different. So it's a really good way to think that you're working in an environment where you can just gather evidence from every single patient you see, and you can use that to then inform all the other patients you see in the way that you treat.
Back to your original point about being critical and thinking about what you're doing rather than just applying recipes.
Yeah.
Well, look, we're going to wrap up part 1 in a minute. We've got part 2. We're going to record part 2 and release part 2 separately of this chat. And the structure for this podcast is going to be the foundational, fundamental skills and knowledge. And then we'll go into a part 2 with guests where we're going to talk about, in more advanced scope, progressing your knowledge. So look, we'll save some more advanced concepts for the next part of our chat. But in terms of wrapping this one up, prognosis. Generally, everyone has a different prognosis, and there's not one answer for this. But generally, who goes well with tendinopathy? Who takes longer? Is there anything that triggers you to think, okay, there's a bit of a red flag, or potentially we're going to have a slower prognosis? They may not respond to treatment. Perhaps a double-barrel question here. There could be pitfalls that clinicians could look out for in terms of prognosis, and people who aren't going to respond to treatment. What do you think?
I think that it's probably true to say that the classic variables that people think about for prognosis, like, you've had it for 10 years, or duration of symptoms, or even things like BMI, they don't really relate to prognosis, especially if you look at them in the research. There may be some evidence that they're prognostic, but not a lot. The variables that haven't really been investigated a lot are some of the psychosocial variables. So it's getting into sort of determinants of health type sort of area, and what impact do these psychological variables have? And I think they do have an impact. So if you're much more attentive and stressed about your pain, it's going to have an impact most likely on what you do. And those sorts of relationships are starting to be untangled now, but we're sort of a long way off really understanding the impact of those variables, but they have been probably not studied enough up until now, and we're starting to get more evidence. So those are the ones that I look at a lot, but you must look at everything like strength. Again, it's that sort of individual approach. Are they really weak? Is that going to be a problem for them getting back? Are they really stressed and anxious and fearful? Are they really unhealthy and overweight? And is that going to be a problem? So they're the sort of domains that you might consider. Very multifactorial, very individualized for different people, I think. But as long as you're critical and you're thinking to yourself, what are the potential factors for this person in front of me that might, just think about it on a logical level. Logically, what if this person was going to do an exercise program, what factors would predict them not having a good recovery or getting stronger? And you could think about it the same with pain. Pain is much more complex than just getting stronger, but what is going to impact their pain not improving? Could it be some of these factors as well? So, that's sort of the way that I would think about it.
We've come a long way from icing and stretching and transverse frictions of tendinitis to, biopsychosocial management of tendinopathy. And, you've taken us really nicely on not just the current, thinking of an expert and the foundations of your expertise and your thinking, but also on a bit of a journey of why current practice is as it is. So thanks, Pete. Really, really interesting, really nice episode 1. Thanks for helping me break the ice.
I can come back and do a full episode on frictions and if you like.
Yeah, good. Good. We'll do that just to be shock jocks, just to get people listening, and then we'll go back to the stuff that works. But
sounds good.
All right. So, and I'm going to be putting your details, where to find you on social media, etc., all in the show notes. So we won't say them here, and we'll wrap up at the end of the second episode, which is progressing your skills and knowledge, part 2. So stay tuned. Listen to part 2 with Pete. For now, thank you very much, Pete.
Thank you very much, Luke. Thanks. Appreciate it.